difficult problem. Let me ask you all one more scenario that actually I faced recently, which is kind of unusual. So I think to Marco's point of cytology 50-50. So we'd had this guy with gastric cancer, young guy, CDH1 was not mutated. We took him for an MSI stable and all that good stuff, but he had a body tumor, and we took him for a laparoscopy. It was a T2 EUST T2. It was a T3 N0 on EUS, and so we did a laparoscopy. He was cytology negative, and then when we went to operate, clearly he had disease along the pancreatic capsule, a little bit more on the lesser omentum, something that we had not seen. The cytology was negative on the initial laparoscopy, and this is post-FLOT. So post-FLOT, you're operating, you're doing your gastrectomy, you encounter this sort of little bit of disease on the pancreatic capsule, or say the transverse mesocolon, something that you had not appreciated either on laparoscopy or cytology. How do you approach a scenario like that? So, Dan?
Yeah, I mean, I agree with you. I always feel a little bit like anxious about it because you say to yourself, was this really progression? Did I not see it before? Thankfully, if you've done the laparoscopy before. We know when we do cytology, it depends on how thorough an exploration of the peritoneal cavity we do. Certainly, if you can, see the tumor, you see it penetrating through the serosa, you're going to see that's high risk. So you know, uh, if they had best systemic, like we were discussing before the conference with Marco, in a young patient, I think it's reasonable. We didn't even talk about total gastrectomy versus partial. I definitely feel much more anxious if a total gastrectomy is going to be required because we know those have higher leak rates without HIPEC. So, knowing you got to sort of know the patient and then certainly counsel them. I probably I wouldn't push for it, but I would entertain the possibility. I think I would do it if you could get the optimal set of reduction. Obviously, that's important, but I agree with you. It's going to be a little bit of wringing of the hands for the next few months to see how they do long term.
Yeah.
Yeah,
Yeah, I don't know. Sanketa, Marco.
yeah, I have exactly the same case, and I unless the tumor board pulls a really hard break, the patient is scheduled for this Thursday. Exactly this scenario. I do have a question for the panelists. Do you routinely do lymph node dissection, like a D2 dissection, during gastrectomy in patients who have